I feel like if we could do one thing to halt or reduce the obesity epidemic, it would be for people not to diet, not to do those types of behaviors, those restrictive behaviors, not to be on that disordered spectrum. Because I think that it may not be the root cause of their high weight, but I think that it adds so much to the baseline issue.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hello.
Great to be here. Hi.
All right, on the show this week, eating disorders and disordered eating. Until today, Dr. Cooper, I did not even know there was a thing called disordered eating, but this is apparently something very closely linked to metabolic issues, and this is a very serious thing when it comes to the health of our population. So let's set a baseline, Dr. Cooper. What is an eating disorder and what is disordered eating?
Well, disordered eating is a term that's used to describe, unfortunately, the behaviors of most of our population. In fact, the majority of the population is on the disordered eating side of the continuum that goes from normal eating to an eating disorder. And the disordered eating includes people that are following diet behaviors, repeated diets, calorie restriction, carb restriction, intermittent fasting, keto diets. Basically, all of those things fall into the disordered eating spectrum, including things that have to do with being overly focused on body image, body shape, body size. And so when you think about it, the majority of people in our country are somewhere on that spectrum where they've overly obsessed with their food, excluding certain foods, worried about eating certain foods. And this goes beyond just like basic health concerns. This is more in an effort to alter your caloric intake and alter your intake of certain food groups repeatedly. And often that can also lead to things like binge eating, because when you swing the pendulum to one side and restrict your food intake, you can end up seeing yourself binging on those same foods that you restricted shortly after that. So people that you see that are focused on these types of things, that would be called disordered eating. And the minority of people in our culture or society are in the normal part of that spectrum where they eat normally. They're not really over-focused on body image. They're not putting a lot of control over their food in terms of cutting out calories or food groups or fasting or joining these popular fad diets. And so that's the minority, unfortunately. And then on the far end of the spectrum would be people that may have started out on what looked like a disordered eating pattern of cutting out certain foods or kind of a restriction and binging cycle, where it progresses into a level that's clinically dangerous, where it slips into something that becomes a really strong medical concern. So it's not that people that are in the disordered spectrum don't have medical concerns. It does cause medical issues if you're in the disordered spectrum. But if you're in the full-blown eating disorder, that can be life-threatening. And that starts to present with certain physical signs and symptoms, and it's much more difficult for a person to come out of that without some serious medical intervention. There's harms along the way for people in the disordered side, which could include things like slowing your metabolism down, blood sugar swings, disease risk increase because we know that with what's called weight cycling, there's an increased risk in visceral fat accumulation, sudden cardiac death, cardiovascular risk, diabetes risk. So weight cycling itself, meaning you're on a pattern where you go on some kind of restrictive diet to force your body to lose weight in the short term, but then the weight comes back regardless of what you're doing. And then you go on another one and you crank up the intensity and you just keep doing these things. That is known to be associated with what's called biologic weight defense, biologic metabolic adaptation, where your metabolism just slows down. But also, it's linked to this increase in this organ fat accumulation and cardiovascular risk. So, especially, it turns out, especially in people who are kind of close to a normal weight level when they do it, not as severe in people who are on the obesity side, like the serious obesity side, in terms of those health implications, but it's dangerous. But it doesn't reach the level where your doctor would say, oh my gosh, you're in a medical crisis, we have to hospitalize you. So the difference is that certain people, and it's not just anyone, the people that would progress from something that looks kind of like a disordered eating into something that looks clearly like an eating disorder, certain people are vulnerable to flip into these eating disorders. And it has to do with their genetics, largely with their genetics. It can be up to 80% genetic, the risk of a full-blown eating disorder like anorexia nervosa. So we have to really think that there's certain people that are very vulnerable. So if they get anywhere on that disordered spectrum, it can propel them straight into a much more severe condition. And so that would be things like diagnosable bulimia nervosa, anorexia nervosa. There's something called ARFID. There's different types of disorders that start to affect your biology in a way that it becomes very dangerous and life-threatening. And those are the eating disorders where you need aggressive medical attention.
So, how long lasting are the effects of disordered eating? Like, do they affect us for our whole life? Do they affect you for a short time? I mean, I think that if you're into the food issues and disordered eating type of knowledge, you've heard that anorexic behaviors can affect you for the rest of your life. But disordered eating, how horrible is that for your metabolism for the rest of your life? Does it mess it up forever? Because I think most of us have had some bouts with disordered eating. And how long does it take for you to recover?
That is a great question because personally, I feel from what I have seen, I feel like it's one of the main reasons that we're increasing obesity epidemic.
Right. We just read that study that came out that said 3/4 of Americans are overweight.
Yeah, and I feel like if we could do one thing to halt or reduce the obesity epidemic, it would be for people not to diet, not to do those types of behaviors, those restrictive behaviors, not to be on that disordered spectrum. Because I think that it may not be the root cause of their high weight, but I think that it adds so much to the baseline issue. But once again, I think whether you're susceptible to long-term effects from these periodic episodes of food restriction, that has a lot to do also with genetic vulnerability. So certain people that are genetically vulnerable to metabolism dysfunction, so if you have diabetes, obesity in your family history, you're going to have more probably of an impact long-term if you go on a restrictive program. And it's not just me saying this, the science shows this. The scientific studies have actually shown that after only a 12-week, not even a severe calorie restriction, but a 12-week caloric restriction that's really commonly done for people, and just a mild to moderate exercise program for that 12-week. They stopped looking at the hormone levels after 18 months because the funding ran out, but they did not return back to the baseline, the pre-diet baselines. And these hormones would be things like leptin. Leptin is that reassuring signal from the body fat that says we weigh enough. Well, After the diet, the leptin became very suppressed and it never returned back to baseline, even though the weight did. Other things like ghrelin is the hunger hormone. After the diet, the ghrelin was very high, the hunger hormone, and it never returned back down to the baseline after 18 months. And there were numerous other hormones that were measured that showed the same thing. This is what we see long term. So with patients, often what will happen is the first thing that has to be reversed is what I call diet damage, because it's how these diets have damaged the metabolic system. And you can't even get to what the root problem was until that's corrected. That involves working maybe with a dietitian to help you get on to the normal ordered side of that eating pattern. And if obviously people need to be screened to make sure they don't have full-blown eating disorders too, where evidence of that would be someone who has a very low heart rate because their metabolism is really slowed down to conserve energy, a low blood pressure, or their blood pressure like drops when they stand too much. So it's not really necessarily a weight thing. It's more of how your body is handling the food nutrition deficits. So it's a hard area, but there's a lot of question about what does it do to your metabolism? But then again, what does your metabolism do to you in the first place that might make you susceptible to these things is another interesting thing to think about.
Well, when you start to describe disordered eating, Dr. Cooper, Andrea and I were talking about this earlier, that it is so pervasive in our society. I mean, we all have friends who have gone to the low carb diet who say they exercise really hard without eating so that they're burning more fat, which is a fallacy. But this whole range of disordered eating is just absolutely pervasive in our culture, isn't it?
It really is. And there's another one where when you're hyper-focused on the food quality, we always think that's great. Eat really high-quality foods. But it can get to a level of like righteousness that just ends up an obsession, and where people will literally starve if they can't get this healthy food. And so that could be on the disordered spectrum, but that also can propel into a full eating disorder, which is called orthorexia, where there's refusal to eat anything that is outside of what is considered like the permitted food. And that can be really dangerous too. And one of the reasons why it's so prevalent is our society, it kind of endorses it and it promotes it, it encourages it. And even, as I said, in the medical community, you'll hear, good for you that you've done this and you have the willpower. But there's no attention paid to what that's actually doing to your health long term or your metabolic system.
Right. It's always considered amazing that you lost all this weight. Isn't that fantastic? You look fantastic. You look great. And it's like, well, what did you do to lose that weight? And is it coming back? Nobody ever talks about that part. It's like a badge of honor when you lost 10 pounds, 15 pounds. I mean, people will I always find, and this is really, sorry, Mark, it's always my guy friends will be like, yeah, lost 15 pounds, lost 20 pounds, lost 30 pounds. They always attach the number. It's really funny. Like, no women will be like, lost 15 pounds, lost 20 pounds, because they are more knowledgeable that the pounds are going to come back. But it's really very funny. Like, it always is about the number or about how much pound. And it's like, pat me on the back. I'm so great. I'm so great. And everyone is about losing. It's sort of the only thing in life where you want to be a loser, you know?
And they don't point out when it comes back, and it does come back, especially these low carb
Behind
diets.
your back, they do.
You know, I'm eating nothing but steak and bacon now, and it's like, oh man.
Well, and it feeds in again. That's disorder. Just the whole concept of being so focused on the weight and the pounds and the body shape and the body size. That is just, as we've always said, that weight and health are not the same. And you can't tell what's going on inside from the outside at all. And so can you imagine a person that's at risk for a full-blown eating disorder that's getting that kind of language thrown at them? Because I have seen people that were on that spectrum of disordered eating, and getting that encouragement and had the genetic predisposition for a full-blown eating disorder that did develop a full-blown eating disorder. And then we're still getting that level of encouragement when they were very sick. And that's where it's so dangerous. And then there can be people too who are starving themselves and their weight doesn't change because they have metabolic dysfunction. And they're being told, you need to eat less. What if they're already not eating anything?
Right. And then there's that depression.
Right. This is the whole problem, really, when you think about it in our society, that health and weight are equated all the time. And it's just so not the way things should be. Even though these are things that data that we track, how they talk about obesity rates and all of this. But it is something to track, I guess. But in terms of the way that it's equated to health, I think that's just really a problem.
So, Dr. Cooper, where is the line between eating disorders and disordered eating? Is there a medical definition of eating disorders?
Yeah, there really is. And it depends on the eating disorder. So again, like say you have something like bulimia, which involves binge cycles associated with purging. So that condition, and the purging could be exercise purging, or it could be vomiting, it could be laxatives, like whatever people are doing to try to reduce their intake or whatever. That may present with someone that's a completely normal weight or an elevated weight or a low weight. It doesn't necessarily present the same way. But what you can see a lot of times is that what I was describing of changes in the vital signs, electrolyte levels, kidney function, just some really alarming things that you can see on lab work and on vitals. But the most important thing is if the patient feels like they cannot break that. They may say they can. They may say, well, I can change this. Same thing with anorexia nervosa, which would be like food restriction or persistent. Sometimes it's associated with exercise, but that would present also with hemodynamic changes, like means the blood pressure, the heart rate, the way the blood pressure regulates from sitting to standing or laying down to standing, lab work that you see. But the patient will tell you, oh, I can change this, but they can't. That's the key of an eating disorder. Once they're faced with this has to change, here's your help and support on an outpatient basis. Here's a dietitian. Here's your maybe a therapist, maybe a physician. Let's see what you can do. They can't do it. They cannot do it without a tremendous amount of support, medical intervention. If you have someone on the disordered end of the spectrum and you tell them, we have this all the time. Every patient we get is somewhere that comes into us is probably on the disordered spectrum. But when we tell them, no, you hired us, we're going to help you with your metabolism, and this is how we want you to switch the way you're eating. Well, here's the dietitian to help you do that. They can do it. They can do it. They do it. They're like, oh, this is weird, different than what I'm used to. And it's a little bit difficult, but it's not something they can't do on their own. When you're in a full-blown eating disorder, it becomes just terrifying to the person, to the point of paralysis. So they cannot make these changes, and they need very specialized, skilled people in the medical field that specialize in these areas to help them. Because one of the issues, there's a biologic feature of the eating disorders. So in a person, when we're hungry, certain famine signals go up in our brain to trigger us to go find food. And so if we don't have an eating disorder, we just don't think about it. We just go find food. But if you're a person that's prone to something like anorexia nervosa, when those signals go up in the brain, it's almost like not having the food can trigger like a dopamine surge, which makes you feel like a boost, basically, by disobeying that biologic cue. And it's not a willpower thing. It's not a brain thing so much. It's more like literally a biologic thing. So that the tendency would be to not eat. It's almost like the signals get backwards. So to not eat creates this boost that feels rewarding and generates endorphins. Endorphins are addictive. It's our natural opiate. So now you've got somebody who's got chemistry in their brain that's addictive to continuing the cycle. And so it is like a biological situation that is literally hard to get out of. It's just like you need that medical support to get out of it. The good news is once the refeeding process starts, like in a situation like anorexia nervosa, once the refeeding begins, it does feel terrible to the patient because all that chemistry changing feels like almost like a drug withdrawal. And there's a lot of physical and emotional symptoms that come on that are real. I mean, they're like definite, repeatable for all the patients that are having these things. And then it gets to a point, though, where the fueling has helped rebalance all of that. And so the reward is no longer there because the famine signals aren't so high anymore. And so there would be no reward. So it doesn't trigger that behavior anymore. So it's really amazing, the recovery process for these things. It's fascinating. But the patients who have these conditions are really like more like a victim of it. It's not something they technically brought on. It's that they are predisposed and they're often just for some innocent reason, they become a little undernourished. It could be they're doing a sport and they're not fueling it right. It could be they got sick with a virus for a couple of weeks and they didn't eat enough. It could be that they did do some kind of behavior, diet behaviors. Grieving and losses often precede it. And so, and there's a benefit to having that endorphins high. It makes people feel kind of numb and a little bit less pain. And so if they were going through something emotional, it kind of feels better. So there's a lot of incentive, biologic incentive to stay in the eating disorder. And that's why it needs this medical treatment. But one thing that's great is that when people truly recover from these eating disorders, they end up on the normal side of that spectrum we talked about because they know they can't survive on the disordered portion of that eating spectrum, or else they'll be at risk of flipping back to the eating disorder. So they become some of the most reliable eaters and the healthiest, really. So there's hope for people that are dealing with that, even though it's so hard. It's like you can become like healthier, than the majority of people when it comes to food.
So interesting, like what your brain does to your body. It's so strange, like how your brain is so connected to metabolism and all the things that it tells your body to do.
Well, and some people have both vulnerabilities. So I see some patients that have a full-blown eating disorder, but when you start talking to them about their history and how it all started, it was because they were trying to manage like an elevated weight at first. That truly was elevated. And so they had some type of metabolic dysfunction at first that was triggering an elevated weight and maybe some other problems. And they started to go on a health plan, to try to improve their health. And in the course of that, they also discovered they were vulnerable to an eating disorder, which they ended up flipping into an eating disorder. So by the time they're in a treatment center, they may have an abnormally low body weight, but then as the refeeding is happening, there's kind of a strange thing happening where their body weight is like elevating, even if, say, in a female, their menstrual cycle didn't return yet. And so there's a lot going on there sometimes. And so when you dig deep, you can see that in that case, the eating disorder was almost like a secondary problem to an initial metabolic disorder that was driving the person towards these behaviors in the first place. And so I think that's really important in the eating disorder world to be making sure people are screened more as they're in the recovery phase for potential metabolic dysfunction, because if it's still there and not really being addressed, you can imagine that the whole cycle could repeat itself, where they could end up at an elevated body weight that then pulls them back into that cycle. So that's where sometimes the full-blown eating disorders were initially kind of triggered by an original metabolic dysfunction. And then other times they weren't, but then they lead to problems with your metabolism over the lifespan in many cases.
So, Dr. Cooper, I'm guessing there may be a few people listening to this podcast who may be struggling with an eating disorder or wondering if they do have it. I mean, you've talked and dealt with so many patients over the years who are in that spectrum. Talk to that person who may be listening and thinking, oh my gosh, what can I do? How do I know if I have an eating disorder? Could you talk to them?
I think it's so critical for a doctor to make the diagnosis. So we also want to talk to the doctors out there, because there's a tendency with doctors to tiptoe around stuff when it comes to eating disorders. And I don't think that's a good plan at all, because the person knows they're in trouble. The patient knows they're in trouble. They want the help. And then the worst thing that can happen is for a doctor to not recognize how much trouble they're in. And that just makes them feel like they're not sick enough, that they've got to go out and prove that they're sick enough to get this help. There's not a person with an eating disorder that doesn't want help. They want the help. And so it starts with seeking the help. If you're in this boat, and this is the hardest thing to do for someone in an eating disorder, to try to be the one to try to find the help for themselves. But to maybe, if you don't feel like you can say much, just say to the doctor, I think I'm in trouble with this, and hope that they get it. But usually it doesn't happen that way. That's why these things are underdiagnosed. It usually is that when they need to be told there's a problem, they're instead at first getting encouraged. And when there are clear signs, instead they're being told, well, your heart rate's low because you're athletic. And it's just, this is what happens. And it gets to a point where it becomes so severe that everyone's panicking all of a sudden, and the person's life's on the line. Mm-hmm. But I just think that maybe the key would be for the healthcare providers to really ask more questions, to not encourage people with these behaviors, and to not just look at someone's weight and say your weight's fine, so you must be fine. Look at all the evidence and ask the questions. But people with eating disorders don't always tell you the truth, because it's part of the disease. To keep the disease going, they don't tell you, I'm not eating my food, or I'm throwing it away, or I'm like exercising every time I eat something. They're not going to tell you that unless you really are someone that appears to be someone they can trust, that understands how this is affecting them. So I think it's a really hard problem, but I think, of course, get medical help. That's the key. You've got to get medical help and specialize. That would be a good advice. If you're not getting any attention in this area from your regular health team, seek out attention from people skilled in eating disorder treatment. There are places, accessible places in most communities, where they specialize in eating disorders. And sometimes it starts with a therapist, although these conditions have been classified as psychiatric, but more and more evidence is showing they're really biologic, as I was talking about. They have psychologic implications, but a therapist isn't going to help you totally recover. You need the therapist to help cope with the recovery process, but you need a medical person who is tracking your vital signs and your vitality and your recovery process from a medical standpoint. And I think dietitians are very helpful also for meal planning, that you have to teach you to do what's called the ordered eating. And so a lot of times all of that is taken away from the patient when they're in a full-blown eating disorder, where they don't have to make initially the decisions of what am I eating, when am I eating. That's all just done for them. And then it gets to a point where more and more responsibility is transferred back to the patient. But for children with these conditions, the parents are very involved too. So if you're a parent and you're worried about your child, then definitely by all means, seek out professional care from a team that's experienced with pediatric eating disorders, because it's not something that can be usually managed as an outpatient once it gets beyond a certain point.
That's great. Just about at time. Andrea, what's your takeaway from our show today?
I would say that the interesting thing is that it's probably, for most people, the disordered eating to eating disorder line probably comes too late, because most people are always in the, oh my God, you look so great. Isn't it great that you lost all this weight? Isn't it fantastic? And then it's almost like you jump off the cliff, Then it becomes the place where, oh my God, you're like a skeleton. So I think that the noticeable time when people would say, oh, I think there's a real problem, It's almost like you're at a too late time to get the help that you might need. So it's a very interesting thing, I think.
Yeah.
From when it goes to, oh, they're eating very healthy, doing the right thing, to when it becomes, oh my God, she doesn't eat. To notice that there is an actual issue going on there. So that's kind of interesting.
Well, and one thing to keep in mind is it doesn't have to be associated with a low body weight. You can be
Oh,
very sick.
that's a very good point. That's a very good
Yeah.
point.
Yeah, you can be very sick with a full-blown eating disorder with a normal weight or even an elevated weight. So
Right.
that's the other thing is that
It's always good for you to point that out. Always
you got to
good.
have that
Yes.
perception that we're putting so much on this weight
Right.
aspect. And it's just ingrained in people, and
Yeah.
people
Like me.
not
Yeah.
like, well, because you've grown up
Right.
where
I
that's
grew up
been
in that world
scrutinized. Yes, exactly.
of not eating.
Yeah. And all of this goes back to, we've talked in so many episodes that the brain really cares about one thing, and that is to not be afraid that it's in a state of famine. And when we talk about disordered eating or eating disorders, we're messing with that system. And the brain does one thing, right? It starts to shut down the metabolism, right, Dr. Cooper? That if you're messing with this in any shape or form, the metabolism is going to slow down and it's going to get out of whack. But I think the thing that I heard you say that's so encouraging, and you've treated so many patients in this spectrum, that there is recovery and there is a beautiful life after even the darkest, bout with eating disorders. So if you're in that category and you're listening, there is help and there is a beautiful life at the end of this if you put in the work. Dr. Cooper, what's your takeaway?
I think that's well said, that there's hope for sure, for people that are in the severe side of it. And yes, they have to put a lot of work into it, but they need a lot of help too, professional help. They can't do it by themselves. It's important to keep in mind that if you are on the disordered side of the spectrum, you can't have a healthy metabolism. Those two don't go together. To have your metabolism the healthiest it could be, you've got to get into the ordered normal side of that spectrum and not engage in things that would classify you as having disordered eating. Because as Mark was saying, once you're in the disordered eating side of the spectrum, your metabolism is taking hits. It's sending out those famine signals. It's slowing down. It's compensating. It's going into conservation mode. So you're not going to have your best energy, your best thought process, your best performance, any of that. So anyway, it's something to keep in mind, is to try to go against the grain of our larger society. And you may stand out, may feel awkward at times when you pull out your food and no one else is eating, but that's kind of what it takes.
I even see you whip out a snack even between podcast episodes
Yeah,
here. And
I'm
I'm always
always-
thinking, man, that's cool.
I know.
She's fueling her body. Well, this has been super enlightening, both of you. Thanks for the conversation. Disordered eating and eating disorders. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.